Good morning, everybody. So, today we are going to learn about acute rheumatic fever. And so, let's begin. What is the definition? It is an acute, multi system, delayed, and immune mediated non suppurative sequel of upper respiratory infection by Group A beta hemolytic streptococci. It is by Group A beta hemolytic streptococci. It is acute, it is multi systemic, delayed, and it is immune mediated. It is non suppurative. These are the key words that you have to remember. Though its incidence has declined, but it still continues to remain a major public health, whatever. Epidemiology, we don't remember. Now, rheumatic fever in India. Why is India considered as a high risk zone? Because prevalence is more than 2 lakh school aged children. Why is it less common now? Because improved socioeconomic conditions, improved antibiotic usage, impact of secondary prophylaxis, general shift in epidemiology. What all things? Socioeconomic conditions have improved. Now antibiotics are present, and then secondary prophylaxis is also impactful. That's why. And then there is genetic shift in epidemiology. What is the pathogenesis? So, first things first, GABH's core throat strains 1 3, that is group A, streptococcus is the agent, and then there are throat strains 1 3 5 18 and 24. So, there are three things that are that make the host more susceptible. Genetic predisposition: susceptible host is between 15 to 5 years of age, and environmental factors such as poverty and overcrowding. Three factors: genetic predisposition, 5 to 15 years of age, and environmental factors, poverty and overcrowding. Molecular mimicry between GABS antigens and human connective tissues and myocardial cells and glycoproteins of heart valves. So there is molecular mimicry between human connective tissue, myocardial cells, and glycoprotein of heart valves. So then there will be exaggerated T cell immune response. Then acute RF will be exacerbated, and then there will be pancarditis or extracardiac manifestations will be there. What are acute mitral regurgitation with carditis. Pancarditis means, and then extra cardiac will be, so that will lead to RSD, rheumatic heart disease, and then extra cardiac manifestation will be Sydenham chorea, subcutaneous nodules, erythema marginatum, and arthritis. What all things? Sydenham chorea, subcutaneous nodules, erythema marginatum, and arthritis. So, what are the five things that we will see in rheumatic fever? First, pancarditis. Second, erythema chorea. Then there will be subcutaneous nodules, and then there will be arthritis. The what are the clinical features? So involves joints, brain, and skin and heart also. Rheumatic fever licks the joints but bites the heart and stings the brain. Sequel associated with cardiac involvement only. Latent period is 2 to 3 weeks. So first there will be infestation, there will be throat infection, and then after 2 to 3 weeks all other symptoms will follow, and chorea will happen 2 to 6 months later. So about 20 to 30 will give history of an episode of sore throat in past 3 weeks. Diagnosis of RF depends upon a sound framework provided by Duckett Jones. So there is Jones criteria, and rheumatic fever, acute rheumatic fever usually presents with acute new onset clinical features like arthritis and carditis. Established rheumatic heart disease, permanent heart valve damage, most common mitral valve, occurs after several months of active carditis. So there are two: acute rheumatic fever, on which the presents are a new onset, the clinical features, and established heart disease means permanent heart valve damage. Most common mitral valve is involved. Now, what are the modified Jones criteria? So modified carditis, arthritis, chorea, what I've mentioned, and then minor will be fever, arthralgia. There's a difference: arthritis, arthralgia, and increased ESR, CRP, prolonged PR, ASO positive throat CS. That means what all minor criteria are, that will be arthralgia, raised CRP, fever, prolonged PR interval, and ASO throat. So rheumatic fever licks the joints. This is what we read. Now essential evidence of recent streptococcal infection in form of positive throat culture, rapid streptococcal antigen test, rising, anti-streptolysin O titer, two major or one major, and two major. See, now how we will see that this is rheumatic fever. So there has to be two major criteria, or there has to be one major and two minor, or essential worst attack of ARF. So exceptions are one major and two minor or three minor for recurrent IARF. If there was ARF even before and now there is ARF, then there has to be one major and three minor or two minor are also okay. And then isolated chorea, no other criteria needed. And unexplained indolent carditis is rheumatic. If there is unexplained indolent carditis, then it is usually rheumatic. Monoarthritis and polyarthritis are now considered as major criteria for high risk zone. Echocardiography is now indicated in all suspected areas of acute rheumatic fever. Echocardiographic evidence of carditis is now considered as a major criteria even in absence of murmur. So, if there is echocardiographic evidence, then there is a rheumatic fever even if there is no murmur. So, what are the major criteria? We'll see in detail. Major criteria are polyarthritis, that means larger joints are involved: knee, hip, ankle, elbow, shoulder. Hip and spine are not involved. So, hip is written, but then again it's written hip and spine are not involved. Okay, the joint pain is fleeting and fleeting. What does that mean? Means fleeting means it will come and go, and fleeting means I don't know. The joint becomes inflamed with painful restriction of movement for 2 to 3 days and then subsides and another joint is involved. So first your ankle will be involved, then your elbow will be involved, like that after 2 3 days. The course is completed within 1 to 2 weeks. Very dramatic response to aspirin. Rarely deforming. If deformity remains, it is called as Jacquard arthritis. Involves metacarpophalangeal joints and forms essential after rheumatic. So there is any deformity, but if a deformity is found, then it is Jacquard arthritis. Carditis. Carditis is common and CHF is rare. Pancarditis, involvement of pericardium, myocardium and endocardium. All the three layers of the heart are involved. Ashkoff body on microscopy of myocardia. Ashkoff bodies are seen. Carditis can be asymptomatic also. Subclinical carditis. Clinical features of carditis are endocarditis, pericarditis, and myocarditis. So, if there is endocarditis, apical blowing hollow systolic murmur of MR with or without diastolic murmur at apex, or early basal diastolic murmur. So, there will be murmur. Remember murmur? If you remember, then remember apical blowing of hollow systolic murmur of MR with or without mild dystolic murmur. Organic cardiac murmurs are not present previously. Congestive heart failure, cardiomegaly. Heart will become huge, cardiac failure will be rare, and then there will be murmur. Then pericardial rub, chest pain, and pericardial effusion will be seen. What all things in pericardium? Pericardial rub, chest pain, pericardial effusion, myocarditis, tachycardia, and unexplained CHF. So, what all things will you see in carditis? Pancarditis, myocarditis, pericarditis, and endocarditis. In endocarditis, you will hear murmur, cardiomegaly, and congestive heart failure. In pericarditis, you will see pericardial rub, chest pain, and pericardial effusion. In myocarditis, you will see tachycardia and unexplained CHF. In Siddham's chorea, delayed clinical features are seen, more common in girls, rapid semi-purposive movements in extremities, and faced with emotional lability. Associated with poor handwriting and poor scholastic performances, latent period more and appears later in life. So, if there is chorea, it is more often in girls, and then there will be rapid semi-purposive movements in extremities and faced with emotional lability. Face will have emotional lability, and you will think that she is going to do something semi-purposive movement, but that she will not do anything. Associated with poor handwriting, her handwriting will be poor, and poor scholastic performance. Subcutaneous nodules. Side will be extensor surfaces of joints. So on knees, elbows, what all things did we see? We also saw arthritis on knees and elbows, and Jacquard arthritis if there is deformity. Time more than 4 weeks after onset of rheumatic fever. Subcutaneous nodules are seen after 4 weeks of rheumatic fever. Erythema marginatum site is on trunk and limbs. On trunk, that means on chest, abdomen, back, and on limbs means hands and legs, means everywhere on the body basically except neck and face. pink macules with central clearing. So there will be outer pink and there will be central clearing spreading serpentiniously like a snake. It will spread. Rarely seen. Some definitions are recurrence means new episodes of RF 8 weeks after stopping treatment. So now you have RF, you had taken treatment. After 2 months or 8 weeks, you again see you have features of RF. Rebound means manifestation of RF on tapering drugs within 4 to 8 weeks of stopping treatments. So you will see 4 to 8 weeks. If you see if you're taking treatment for RF, you're tapering drugs now, and after 4 to 8 weeks, you will see that there is a rebound RF. Relapse means worsening of RF under treatment. Relapse means you are taking treatment, and even in that treatment, you are not progressing, you're deteriorating. So, in tip will be involvement of mitral valve is 95 and aortic is 20%. Myocarditis without valvulitis is unlikely to be rheumatic. In typical polyarthritis, simultaneous cardiac chorea are rare. Response to aspirin is dramatic. So, any valve that does not respond to aspirin is likely to be rheumatic. Now, what are the investigations? CBC, ESR is raised and CRP is raised. CBC is raised, ESR is raised, and CRP is raised. Chest X-ray, cardiomegaly will be seen, ECG will be prolonged, 2D carditis. All the features will be seen. Evidence of previous streptococcal infection, so ASO and anti-hydrogenase and anti-DNase B. Anti-streptolizin O will be seen. ASO means anti-streptolizin O, anti-hyaluronidase and anti-DNase B. Positive in 60 to 80%, peaks at 3 to 6 weeks after infection. Now 2D echocardiography. It suggests rheumatic carditis, and criteria for carditis on echo are mitral regurgitation, and aortic regurgitation. So if these criteria are there, then rheumatic heart disease is there. What are criteria? ESR is raised, CRP is raised, CBC we have to see. Then on chest X-ray you will see cardiomegaly. On 2D echography you will see carditis. Then we'll see positive anti-streptolizin O and anti-hyaluronidase and anti-DNase B. Then you will see on echo that there is mitral regurgitation and aortic regurgitation. What are the differential? There is carditis, arthritis, and chorea. Chorea is also seen in Wilson's disease and Huntington's chorea, GIA, and viral myocarditis. What are the complications? So there will be mitral regurgitation, mitral stenosis, and aortic regurgitation, and infective endocarditis. Mitral regurgitation, mitral stenosis, aortic regurgitation, and infective endocarditis. What is the treatment? Treatment will be bed rest for arthritis 2 weeks. If there is mild carditis, 4 weeks. If moderate to severe carditis, then 6 weeks. What all? If there is arthritis, 2 weeks. Cardiac 4 weeks. If there is moderate to severe carditis, then 6 weeks. Treatment of streptococcal infection will give penicillin 5 to 50 mg orally 2 times for 10 days. Benzathine penicillin. So mainstay you have to remember penicillin, benzathine penicillin, and penicillin normal. Benzathine 6 lakh units will give if the weight is less than 27 kgs. Then treat CHF by anti-cardiac drugs, and then anti-hypertensive anti-hypertensive drugs, and also like beta propranolol and all. Then control group A streptococci. Benzathine group penicillin 6 lakh units. Cephalosporin can also be used. And then anti-inflammatory treatment, cornerstone of the management. So there has to be anti-inflammatory treatment. You'll have to give steroids and aspirin. Treatment of rheumatic arthritis is aspirin 100 mg per kg per day for 2 to 3 weeks. Aspirin 75 mg per kg per day for 2 to 3 weeks. Mild carditis, aspirin 100 mg per kg for 2 to 3 weeks. Aspirin 75 mg per you'll have to give aspirin 100 mg per kg for 2 to 3 weeks till ESR is normal, and then aspirin 75 mg per kg for 4 to 6 weeks, total 6 to 8 weeks. Understand? 100 mg first, then 75 mg per kg per day. Then moderate to severe carditis, you will have to give prednisolone 2 mg per kg per day for 2 to 3 weeks. After 2 weeks, add aspirin 75 mg per kg per day for 6 to 8 weeks. So what you'll give prednisolone 2 mg per kg for 2 to 3 weeks, and then you'll taper over 2 weeks, and then you'll add aspirin. Steroid aspirin overlaps for 2 weeks. Treatment of rheumatic chorea, you'll give A late manifestation, hence ASO may be normal. Reassurance as if it is self-limiting, though phenobarbital and haloperidol can be used. So for chorea, you'll give phenobarbital and haloperidol. Treatment of long-term complications are surgery for MS-MR to re-establish heart disease, rheumatic heart disease. Early suspicion of streptococcal sore throat, follicle exudate on throat examination, and tender jugulodiagnostic lymph nodes. You will have to do early suspicion if there is sore throat, follicles and exudate on throat infection, and tender jugulodiagnosis. So, what is the treatment? So, the mainstay of the treatment is that you will have to first treat the streptococcal infection with penicillin, which is penicillin 5 with 250 mg orally per 2 times a day for 10 days, and then you have to give benzathine penicillin 6 lakh units for if the weight is 27 kgs or less. And then for mild carditis, arthritis, and severe, there will be rest. Arthritis 2 weeks, mild arthritis 4 to 6 weeks, and then 6 weeks. Then there is for anti-inflammatory treatment, you'll have to give steroids and aspirin. Aspirin you'll give 100 mg per kg per day for 2 to 3 weeks till ESR is normal, and then 75 mg per kg for rest 4 to 6 weeks, so total 8 weeks. And then in moderate to severe carditis, you'll have to give prednisolone 2 mg per kg per day for 2 to 3 weeks, and aspirin. Then for treatment of rheumatic chorea, you don't have to do anything, but you can give phenobarbital and haloperidol. For prevention, what all you'll do? Primordial prevention means streptococcal sore throat, example prevention of overcrowding. So first things first, you will not go to overcrowded places. You should not be poor. Illiteracy, you should be educated. That is not possible for everybody, but you should at least try. Government should try for eradication of overcrowding, poverty, and illiteracy, and vaccine. Primary prevention, early clinical suspicion of streptococcal throat and its treatment with full 10-day appropriate. You should not stop the antibiotics in between. If you have strep throat, take cephalosporin or amoxicillin. Secondary prevention means all patients recovered from acute rheumatic fever should prevent recurrent. So they should take a benzathine injection IM every 21 days after negative test done. So once in a while they should take benzathine penicillin. In patients allergic to penicillin over erythromycin daily. Who suggests 6 lakh of IU for children? In case of non-availability of benzathine penicillin, oral penicillin may be used. Duration of prophylaxis 5 years for acute rheumatic fever, 10 years for carditis, lifelong for RHD. If it is rheumatic fever acute, then only for 5 years. Only 5 years is also long, but still 10 years for carditis and lifelong for RHD. Tertiary means treatment prevention of complication of established RBC. Early suspicion in streptococcal sore throat, follicles and exudate on throat examination, tender jugulodiagnostic lymph nodes. Thank you guys for watching.